The following podcast is part of a certified educational activity featuring Dr. Michael J. Fisher, Conchetta DiDomenico, Andrea Rennie, and Catherine A. Smith from the Children's Hospital of Philadelphia. Access the entire activity and complete the post-test at peerview.com/BQF860. Downloadable slides and practice aids are also available.
Hello, and thank you for joining us today. We're going to be presenting about targeting the RAS-MAPK pathway in neurofibromatosis type 1, plexiform neurofibromas, and optic pathway gliomas. Tonight, our faculty includes myself. I'm Connie DiDomenico. I'm a nurse practitioner in neuro-oncology. Dr. Michael Fisher, who is our neuro-oncology section chief and the director of the Neurofibromatosis program at CHOP. Andrea Rennie, our neurofibromatosis program nurse navigator, and Katie Smith, our clinical research nurse. So just to give an overview of our agenda this evening, we will start with a closer look at neurofibromatosis type 1. Then we will explore the current standards of care and future potential or targeted therapies in NF1 associated plexiform neurofibromas and optic pathway gliomas. Then we will do some case presentations about perspectives on managing NF1 in children and adolescents. And then we'll take the time to recap, take some takeaway points, and have time for questions. So I'm going to turn this over to Andrea now to give us a closer look at NF1.
Thank you, Connie. We'll get started. So neurofibromatosis type 1 is an autosomal dominant disease, and it literally affects almost every system of the body, as you can see here. So from an epidemiology standpoint, the incidence is 1 in 3,000 births. Again, this is an autosomal dominant disease. It is completely penetrant. The challenge is that it has a highly variable phenotype. So in up to 50% of these cases, they're sporadic and new to family, leaving the other 50% to be inherited or familial. The challenge is that even amongst family members with the same disorder, they have a highly variable phenotype and manifestation of their disease. The NF1 gene is mapped to chromosome 17, and the protein product involved is neurofibromin, and we'll discuss that in a moment. It is a tumor suppressor and a negative regulator of the oncogene RAS. And so again, although it's found in over 95% of the population, there really is overall very little genotype and phenotype correlation. However, as we're beginning to look at larger data sets, we can see some emerging genotype and phenotype correlations. To speak to this briefly, there are some large deletions that are NF1 microdeletions associated with a much more severe phenotype, NF1 in-frame deletions with a much milder phenotype, and pathogenic variants showing a higher chance of developing symptomatic spinal NF neurofibroma. NF1 is a tumor predisposition syndrome, and the main takeaway from this whole slide is that you have an increased risk of malignancy as high as 10%. And so we won't go through each of these, but we will speak some tonight on malignant peripheral nerve sheath tumor, as well as CNS gliomas, including optic pathway glioma. So this is a diagram of how NF1 tumors develop. And so neurofibromin, that we mentioned briefly a moment ago, regulates RAS signaling. And when neurofibromin is missing in a cell, there is unregulated RAS signaling down its effector pathways, leading to tumor formation and therefore proliferation. So how do you diagnose NF1? NF1 is a clinically diagnosed disorder. And so in order to make this criteria, patients must have 2 or more of the following criteria, and then you can make a clinical diagnosis. These include cafe au lait macules, skin fold freckling, neurofibromas, Lisch nodules, optic glioma, skeletal dysplasia, or a first-degree relative with NF1. It's important to know that most patients are not going to present at birth meeting criteria. However, by the age of 1, 70% have been diagnosed, and by the age of 8, 95% of patients have met clinical criteria. So we'll go through these briefly. Cafe au lait macules are sort of the hallmark of NF1. They are present in over 95% of patients, and interestingly, 10% of the normal population will also have 1 to 2 on their skin. Skin fold freckling is very common, most common in the axilla and the inguinal region. Different than the cafe au laits, though, these are not apparent at birth. Onset is around age 3 through adolescence. Lisch nodules are also extremely common, present in over 90% of patients, And again, the onset of these is not until after 3 years of age. These are simply benign hamartomas of the iris. Long bone dysplasia is the thinning of the cortex or the long bone, and the tibia is the most common. And in these patients, you will see bowing that's apparent in the first few months of life. And so the risk is for tibial pseudoarthrosis. And so patients coming in to be diagnosed prior to walking will have x-rays done to see if they do in fact have fracture and then be referred appropriately to orthopedics. Sphenoid wing dysplasia is extremely rare, occurring in less than 1% of patients, but as you can see from the picture, the real risk here is that the temporal lobe can herniate into the orbit. So again, extremely rare, but is one of the criteria. Cutaneous and subcutaneous neurofibromas, however, are extremely common in over 99% of patients. They're very small and discrete nodules that develop on or under the skin along the nerves, so basically anywhere in the body. These cutaneous neurofibromas on this slide, you can see they grow on the skin and they're very soft and fleshy. And then on this, you can see the subcutaneous neurofibromas, and these grow below the skin. They're firm and they can be tender or pruritic. So the following slide is going to talk about some complications. These are not diagnostic criteria, but often arise for patients. They can have short stature or macrocephaly. Up to 25% of patients can have scoliosis, which can be associated with a paraspinal plexiform. Patients may present with seizures. They can also present with a headache that may not be controlled by a non-prescription medication. They may just have a completely abnormal neurologic exam, and in either of these cases of seizing or headaches, you would want to consider MRI to rule out tumor. There are numerous vascular complications that can be involved, and we won't go through all of these, but we want to think about renal artery stenosis, specifically for kids. They are at risk for this. And so from a nursing standpoint, thinking about times where you would see patients and have vital signs and blood pressures, you would want to think about notifying the NF provider if you see a trend in their blood pressure, as children are at risk for renal artery stenosis. Cerebrovasculopathies are also a complication, including a subset of these patients having moya and an increased risk for stroke. And so those children are followed by stroke and neurology teams. So one of the most concerning challenges for NF patients is cognitive problems. Up to 65% of patients experience various problems with cognitive challenges. They can have executive dysfunction or a lower IQ than 70. Patients often have ADHD, and up to 70% of school-age children are underachieving in school in reading, spelling, and math. And this is a huge opportunity for multidisciplinary teams to really partner with schools and educators to look at ways that we can provide resources and tools for these children to succeed. Social dysfunction is also a huge challenge for these patients and families. Compared with their peers or unaffected siblings, they are much more socially isolated, express feelings of loneliness, often bullied, and unable to reciprocate friendships. There's also youth with NF1 have much higher rates of ASD than the general population. And so there are significant levels of ASD symptomatology, up as high as 43 to 60% associated with youth with NF1. So when do you want to perform germline testing? And so I can tell you that most pediatric centers do not routinely run germline testing. There are times, however, for a child that you want to consider sending germline testing. And this would be if you have an uncertain diagnosis. So it may be that your patient did not meet clinical criteria. It could also be that they presented with only cafe au lait macules and freckling. And so in this case, you would want to send germline testing to rule out Legius syndrome. Legius patients are going to present similarly, but over time will not develop tumors. And so their follow-up and care will actually be very different than NF patients. If your patient has multi-level spinal neurofibromas without other manifestations, you would also want to send germline testing. And then as you think about adult care for NF1 patients, family planning and germline testing are very useful together. So the standard of NF care really consists of a solid yearly physical and exam and history. And so this needs to be done by an NF expert, whether that is a pediatrician with NF expertise or an oncologist or a geneticist. But you build from that and really are able to screen for things like OPG, plexiform neurofibroma, and MPNST. So to touch on those briefly, optic pathway glioma, there's much discussion in our field about whether the best surveillance is really MRI versus ophthalmology. I can tell you that most institutions, ours included, really rely on the ophthalmology exams yearly until age 8, and then every other year until age 18. If we find an abnormality in the exam, then we certainly refer for an MRI and utilize that in that way. For plexiform neurofibroma, you've done your history and physical, and then if clinically warranted to look for plexiform, you would do an MRI. For MPNST, you've also done your history and physical, you've done the MRI, but now when there's something concerning there, you would want to move to a PET scan. And the reason for this is that MPNSTs have a much higher uptake of glucose, and therefore you can distinguish the MPNST from the non-transformed plexiform. And then this last point is raising the discussion about whole body MRIs for late teen patients to assess for tumor burden. And whole body MRI is a discussion, but it is not a standard practice in our field. The emerging consensus is about the discussion of scanning these older teens to look for tumor burden, with the thought that if I have a larger amount of plexiform, there is a higher likelihood that one of those would transform in time. Not that this is something that's happening immediately, but over your lifetime, a higher likelihood. So this has been a discussion of overall clinical care guidelines. And then these articles talk about supervision of children with NF1 as well as adults. There are also publications in the works for care of patients with OPG as well as plexiform.
Thank you, Andrea. Now we're going to move on to the current standards of care and future potential of targeted therapies in NF1-associated plexiform neurofibromas and optic pathway gliomas. And Katie is going to start us with the plexiform neurofibromas.
Thank you, Connie. So there are various types of neurofibromas and nerve sheath tumors that can be split into 4 broad categories: dermal neurofibromas, plexiform neurofibromas, atypical plexiform neurofibromas, and malignant peripheral nerve sheath tumors, or MPNSTs. Dermal neurofibromas are not technically nerve sheath tumors, and these have no risk of transforming to malignancy. The other 3 fall on a continuum of nerve sheath tumors, ranging from benign plexiform neurofibromas to MPNSTs. Atypical neurofibromas fall in the middle of this continuum, where the tumor has acquired some genetic mutations, but not as many mutations as the malignant tumors, though there is always a cause for concern for malignant transformation. We will focus primarily on plexiform neurofibromas in this presentation. So plexiform neurofibromas are benign, low-grade peripheral nerve sheath tumors, and they occur in upwards of 40% of patients with NF1. Plexiforms grow along nerves and nerve branches, and they can grow anywhere in the body where there is a nerve or nerve sheath, so just about anywhere in the body. The actual tumorogenic NF-, cell is the Schwann cell, but we know that plexiforms have many other cell types that contribute to its formation, including fibroblasts and mast cells. The natural history of any individual plexiform is highly variable, and growth rates of individual plexiforms are unpredictable. Most plexiforms are not growing or are growing slowly, and while they are thought to be congenital, the tumor may or may not be apparent in very young children, depending on the location. Plexiforms are more likely to grow or have faster growth rates in early childhood, and most stop growing on their own without intervention by the end of the teenage years. The most concerning complication of plexiform neurofibromas is malignant transformation to an MPNST. However, even benign tumors can cause many morbidities, such as pain or impaired function from nerve compression. You can see an example of a tumor in the arm in the top left picture on this slide. In these pictures, the plexiform appears as bright white. Plexiforms can also cause significant disfigurement, especially in the face, and you can see an example of this in the top right picture. Complications can also be life-threatening, especially if they occur around and compress the trachea, large blood vessels, or the spinal cord. You can see an example of this in the bottom picture showing airway compression, where the black area showing the trachea should be midline, round, and circular, but as you can see here, the tumor is having significant impact on this structure. Until recently, surgery was the only known effective therapy for plexiform neurofibromas, but the ability for complete resection is limited. It is very challenging to remove most plexiforms without damaging the nerve they surround and therefore sacrificing function, and bleeding is also a problem with how vascularized these tumors are. Radiation has not been proven to benefit this type of tumor, but it is known that radiation in patients with NF1 is associated with a 2.8-fold higher risk of secondary malignancy, so generally we try to avoid radiation in patients with NF1 if at all possible. Additionally, no traditional chemotherapy agents have been proven to work for this kind of tumor, and since NF1 is a tumor predisposition syndrome, we try to avoid therapies with mutagenic potential. Until recently, molecularly targeted agents have only been experimental, and Dr. Fisher will discuss this more in the next several slides.
Thanks, Katie. So before we sort of talk about clinical trials of plexiforms, it's important just to understand the various phases of testing of new agents in humans. And so these occur in 4 phases. Phase 1 studies are really about safety. It's trying to determine the ideal dose for treating the tumor that is safe to give. Once you've identified that dose, you usually take it into what's called a phase 2 study. And in a phase 2 study, you're getting a preliminary readout of whether you're getting a response with this drug, so how effective it is, and you're still getting some additional safety information. From there, if you've got an active agent, in most cases, you go to a large phase 3 study where you're evaluating this drug now in a randomized fashion, often compared with the standard of care. And then once a drug is approved, there's often post-marketing studies looking at long-term safety and tolerability. So I'm going to go through a bunch of clinical trials that have been done for plexiform neurofibromas over the years. And, there's been, probably close to 20 in the last 15 years. I'm going to focus on a couple that taught us some lessons. And then as we move forward, you'll see new agents that are showing some real promise. So these are 4 studies that didn't necessarily change the field, but taught us some really important lessons. The first was a randomized study of tipifarnib, which is a farnesyl transferase inhibitor, versus placebo. And while the tipifarnib didn't work, this was a crossover design that allowed us, with the placebo arm, to understand the natural history of tumor progression in plexiforms. The NF Clinical Trials Consortium did a study of the Mtor inhibitor sirolimus a bunch of years ago and compared it to this natural history arm from the tipifarnib study. Unfortunately, the Mtor inhibitor didn't give us any responses, and there was a slight but modest increase in time to progression. More recently, there was a study of pegylated interferon. And in this case, once again, not much in the way of response or symptom improvement, but this drug did actually extend the time to progression by almost 2-fold. And then there's a study of the mast cell and c-KIT inhibitor imatinib, which showed some minor tumor responses, but some symptom improvement, particularly in patients with airway tumors. More recently, the NF Clinical Trials Consortium did a phase 2 trial of cabozantinib. Cabozantinib has multiple targets, so it's a receptor tyrosine kinase inhibitor, but we believe it works by targeting the tumor microenvironment and angiogenesis, which is the process by which tumors recruit a blood supply. This study enrolled patients 16 and above with inoperable plexiforms that were either progressive or causing significant symptoms. And the mark of response in this study and the subsequent studies is a 20% reduction in volume of the tumor. What you'll see here on the left is a waterfall plot of response. What that means is the bars going up are growing tumors, the bars going down are tumors that are shrinking. The red line marks the bar of partial response, and we had 42% of patients have a partial response. This was very well tolerated with few grade 3 adverse events and no grade 4 adverse events. And this was promising enough that the NF Clinical Trials Consortium opened up a cohort enroll children 3 to 15, and that's almost completed enrollment. So let's shift to the focus of this session that we're doing, which is targeting MEK for NF tumors. So as Andrea told you earlier, when you're missing neurofibroma and you have increased signaling down RAS effector pathways, including the MAP kinase pathway, and the concept of using a MEK inhibitor is to try and block the over-signaling of this pathway at a protein called MEK. And there are various MEK inhibitors out there in various stages of evaluation for NF tumors. The best studied is Cellumetinib. So initially, Cellumetinib was studied in children with inoperable high-risk plexiforms, defined as plexiforms with the potential to cause morbidity. And it was studied in a phase 1 fashion where we evaluated doses from 20 milligrams per meter squared up to 30 milligrams per meter squared. 24 patients were enrolled. It was well tolerated. The dose-limiting toxicities are listed there. They include asymptomatic increase in creatinine kinase, asymptomatic decreases in left ventricular ejection fraction. There was a surprisingly increasing number of cellulitis, and then acneiform rash. But in the end, the recommended phase 2 dose turned out to be 25 milligrams per meter squared BID. And I'll point out that's about 60% of the recommended dose for adults with cancers. And part of that is patients with low-grade tumors often are not as willing to tolerate low-grade toxicities. The amazing thing about this study is that it was its response rate. And I'll remind you, the goal of a phase 1 study is to evaluate safety. It's actually pretty surprising to get more than a 10% response rate in a phase 1 study. But in this study, you can see from the waterfall plot, there was a 71% response rate, and there were responses at all of the dose levels that were evaluated. So on the strength of that, as we went to phase 2, we decided that this was so exciting that the phase 2 study would be designed as an FDA registration study. Right, so it was a process where we weren't planning to go to phase 3. We were going to make this the definitive study. So this enrolled patients, children who were 2 to 18 years of age, at the dose that was defined in the phase 1 study. The primary endpoint, once again, was tumor shrinkage by MRI. But in this setting, the FDA said to us, well, it's great if you can get these tumors to shrink, but can you tell us that the patients feel better once you shrink the tumors? And so every patient had to have functional endpoints and patient-reported outcome measures included. And this shows you how complicated this can be because the tumors were in all sorts of locations, and the functional outcomes had to be individualized. So this is a patient with a neck, upper mediastinum, and arm tumor. And so because of that, the tumor compressed the airway, and so there needed to be airway endpoints of sleep study and pulmonary function tests. And because it was in the arm, we had to evaluate strength and range of motion routinely. And because it was disfiguring, we did regular pictures and video. The study enrolled 50 patients over a 1-year time period. The median age of the patients was 10 years, and you can see that these were large tumors, on average almost 500 milliliters. The other thing to point out is that each patient had between 1 and 5 morbidities from their tumor, with a median of 3. And as you can see in this waterfall plot, the phase 2 study confirmed the really impressive response rate that we saw in phase 1. You can see there's a 74% response rate and a 68% confirmed response rate. And not only that, the patients had improvement in quality of life and function, so that the figure over here shows that most patients have an improvement in quality of life. And in this patient here, you see the graph on the right with the tumor growing until they start Cellumetinib and then the tumor shrinking. And if you can see by the arrow, this child has a large disfiguring tumor, and you can see how the appearance looks better after the tumor shrinks. I will caution you that we've learned over the years that it appears that you need to continuously dose the Cellumetinib to maintain these responses. So this is an example from the phase 1 publication of a patient who had a tumor that grew pretty steadily over 10 years. You can see by the green arrow when we started Cellumetinib, the tumor shrank, but the drug had to be held because this patient had an asymptomatic drop in cardiac function. Over time, with holding the drug, the function improved. The patient was able to restart Cellumetinib at a lower dose, and the tumor shrank again. And at least as of now, we believe that you have to maintain dosing for plexiforms to maintain this response. This data was so impressive, the FDA reviewed it, and on the basis of this study, actually approved Cellumetinib in April for the treatment of children 2 to 18 years with NF1 and inoperable plexiforms that are symptomatic. The dosing is the dosing we took forward from the phase 1, and I'll point out that the doses are available in 10 milligrams and 25 milligram tablets that have to be swallowed whole. There are other MEK inhibitors in evaluation that are not approved at this time. So the NF Clinical Trials Consortium did a phase 2 study of the MEK inhibitor Mirdametinib for adolescents and adults with plexiform neurofibromas. This study enrolled 19 patients with large tumors that were symptomatic or growing. And you can see here in the waterfall plot that there was a 42% response rate, also quite well tolerated. Now you may look at that and say, 42% is not as good as 70%, but I would caution you, these studies are actually not designed to be comparable, and the patient population is different. One study, the study of Cellumetinib, was in children, and this study was performed in adults, and there may be differences in how tumors respond based upon age. In addition, the NF Clinical Trials Consortium is also evaluating the MEK inhibitor Binimetinib, and we're evaluating this in both adults and children with plexiforms. This study has completed enrollment, but patients are still on, so we don't have response data yet. So I'm going to sort of end this section on plexiforms by just sort of giving you how I think about who needs treatment. Katie pointed out that most of these tumors aren't growing and don't need treatment. So how do you decide? And so I think about a bunch of different factors. So the first thing I ask myself when I meet a patient is the tumor growing or not, right? Because if the tumor's not growing, then they may never have a problem. The next question is there morbidity? Does the patient have pain, disfigurement, a functional deficit, or is there impending morbidity? Let's say I have a tumor right up against the airway and it's growing, which means that the airway compression could get worse. And then I consider the age, right? Katie pointed out to you that younger children are more likely to have growing tumors, but towards the end of the teen years, most tumors, even if they were growing in NF, stop growing. And the point I want to make here is when you think about all this, in most cases, stable tumors not causing morbidity should be observed because they may never grow significantly or cause symptoms. So now, what about if treatment is indicated, right? You've got a growing tumor causing symptoms. Then how do you decide now between surgery versus a medical treatment like Cellumetinib or a clinical trial? So I think about these in the following ways. When I think about surgery, the first question I want to ask myself is it resectable without significant morbidity, right? So can I get it out without harming the patient? And then I want to think, how involved is this? Is this a single surgery, or is the patient going to have to go through multiple surgeries? And what's the recovery time going to be? As I think about whether to pursue something like Cellumetinib or offer a clinical trial, I want to think, are there specific contraindications or concerns about using a particular therapy? Or I want to think about, how quickly do I need to get an effect? For example, if I have a tumor compressing the spinal cord and the patient has had acute neurological decline, then I'm likely going to lean towards surgery so that I can get that tumor off the cord rapidly, because even with Cellumetinib, the tumors don't shrink quickly. But the bottom line is these are complicated decisions that you need to be making in a multidisciplinary team that includes the NF provider, the oncologist, the surgeon, your radiologist, and others. So with that, I'm going to pass off back to Connie to shift into a discussion about optic pathway gliomas.
Thank you, Mike. Now we're going to look at optic pathway gliomas. So 20% of those patients with NF1 will develop low-grade gliomas, and these commonly involve the optic pathway and brainstem. But to focus on the optic pathway gliomas, these typically occur in young children, mostly under the age of 7, and they can result in vision loss, but don't always. And the take-home message here is that a change in MRI doesn't necessarily correlate with visual outcomes. And because the goal is to preserve vision, partnering with neuro-ophthalmology is crucial when deciding when to treat. The problem is that most NF1 low-grade gliomas do not need treatment, and there's a limited understanding of which tumors are likely to require intervention. So identification of prognostic factors is crucial to minimizing the morbidity of these tumors, as well as to limit treatment to those only at-risk tumors. Standard therapies for symptomatic NF1 low-grade gliomas are limited compared to sporadic or non-NF1 low-grade gliomas, and they have a higher risk of morbidity in NF1. So identifying new potential targets for treatment for NF1 low-grade gliomas is crucial, and this is what we're most excited about. As I mentioned, deciding who to treat in NF1 is challenging, particularly in optic pathway gliomas. And unfortunately, this discussion here is beyond the scope of our talk today, but you can refer to this figure published by Peter Blanc, which shows ways to think about who to treat. So to look at current NF1 low-grade glioma treatment, when we're thinking about treatment, how do we decide? So while surgery is a good treatment for low-grade gliomas in general, this is not often pursued because of its risk for further compromise of vision. And the exception to that, however, would be in a blind eye, as pictured here, with associated pain and proptosis. Radiation therapy is another consideration for low-grade gliomas, but for NF1 optic pathway gliomas, you risk further vision loss, risk for secondary malignancies, and progressive cognitive delay in these very young children. Therefore, our frontline therapy for NF1 optic pathway glioma is chemotherapy. Carboplatin is our standard frontline because of the lower risk of secondary malignancies such as leukemia. So over 65% will see a response rate, and some research will say that about 30% of patients will have improvement in their visual acuity. Okay. So there is no standard second-line chemotherapy for patients with NF1. Other standard chemotherapy regimens are avoided in NF1 because of the concerns for leukemia risk. So other therapies that have been employed are those that target angiogenesis, such as a metronomic weekly schedule of vinblastine, and then those that target the blood supply of the tumor, such as bevacizumab or Avastin. But what we're most excited about is the potential for molecularly targeted agents like MEK and Mtor inhibitors.
Thanks, Connie. Similarly to plexiforms, there's a lot of interest in MEK inhibitors for gliomas in NF1. Part of that interest is driven by this Pediatric Brain Tumor Consortium phase 2 trial of Cellumetinib that was done in patients with recurrent low-grade gliomas, and they had a specific stratum for NF patients. So they enrolled 25 patients with NF, 13 of whom had optic pathway gliomas. So the rest were gliomas in other parts of the brain. And as you can see from this waterfall plot again, an excellent response rate. Here for gliomas, response is defined as 50% tumor shrinkage by area. So the response rate was 40%, but when you look at the bars, they're pretty much all going down. And so really impressive 2-year progression-free survival of 96%. And with a median follow-up of almost 4 years, 17 patients still had not progressed. This was exciting enough data that the Children's Oncology Group has now launched their first phase 3 low-grade glioma study in almost 2 decades. And they've launched a particular study just for NF1 associated low-grade gliomas. And so this is a phase 3 randomized study for the treatment up front, so previously untreated NF1 low-grade gliomas, and patients are randomized to the standard of care, carboplatin, vincristine, or cellumetinib. And the primary objectives of the study are to determine if the event-free survival, meaning tumor control, is similar between the two. So it's a non-inferiority design, meaning the belief is if cellumetinib is as good at controlling the tumor as carboplatin, that people would prefer taking an oral medicine. But equally exciting and important is that this is the first phase 3 clinical study which is a co-primary outcome of visual acuity outcomes. And the design here is to see if cellumetinib patients who receive cellumetinib have better visual outcomes than those that receive carboplatin. So this enrolled a few months ago and is currently enrolling, but very exciting. So we're going to move away now from a discussion of gliomas, and I just sort of want to summarize this section by just showing you this table, which gives you an overview of the current status of MEK inhibitors for NF1 tumors. And you can see the various MEK inhibitors listed at the top of the table. And for plexiform neurofibromas, as I mentioned, cellumetinib is FDA approved, but at least 3 of the other MEK inhibitors are in trial. For low-grade gliomas, multiple MEK inhibitors are in clinical trial right now. So I'm going to hand back to Katie to discuss some of the things you need to be aware of when you use MEK inhibitors for treatment, as well as some of the practical prescribing issues.
Thank you, Mike. So it's important to recognize that these medications do come with quite a few potential toxicities that should be monitored closely. Rash is one of the most common side effects from these medications. In young patients, an eczema-type rash may occur, and severe acne may be seen in adolescents. Paronychia is another skin toxicity that may be seen in patients of all ages. Additionally, patients may experience some GI side effects, such as nausea, vomiting, or diarrhea, and these symptoms may occur intermittently. We also monitor all patients for ophthalmologic toxicity, the most concerning of which is retinal damage. As these drugs are new and we don't yet have long-term follow-up data, there are some concerns about whether or not these medications may impact development, but we have not seen any signs of this to date. In thinking about prescribing considerations, it is important to note that many MEK inhibitors must be taken on an empty stomach, meaning no food 2 hours before or 1 hour after taking the medication. It is important to discuss this with families, especially for medications that are taken twice a day, as this works out to 6 hours each day when the patient cannot have anything to eat or drink other than water. It is also notable that this medication is metabolized through the CYP3A4 pathway, so caution should be used when prescribing in combination with other CYP3A4 inhibitors or inducers. We also caution patients to avoid sources of high vitamin E, including multivitamins. As far as monitoring goes, patients should be followed with regular clinical exams, labs including CBC, CMP with a MAG and a FOS, amylase, lipase, CPK, as well as periodic echoes to monitor left ventricular ejection fraction, ophthalmologic exams to monitor for retinal toxicity, and MRIs to evaluate the status of disease.
So now we're going to take the opportunity to do some case presentations on managing NF1 in children and adolescents. So case 1 is an 8-year-old girl with familial NF1 and a right face, orbit, and neck plexiform neurofibroma. Her prior surgeries have included, at the age of 2, debulking of her right upper eyelid, ptosis and ptosis correction. At the age of 5, debulking of her right face, forehead, palate, and upper lip. And at the age of 7, debulking of her left cervical plexiform neurofibroma. So I pose this to you, Mike. Would you treat this patient's tumor? Treat this patient's tumor.
So, let me go back and sort of take you through or remind you of the slide I presented a little while ago about how I think who to treat or not. So this patient was referred to me. I would start with those 2 initial questions, which is, one, is the patient progressive? Is the tumor progressive? And what I can tell you is that this tumor had increased in size by less than 20% in the prior 18 months. Just to remind you, the definition of progressive disease is a 20% increase in a year. So the tumor was growing a bit, but not at a rapid rate. The next question is there morbidity? And the answer is yes, and quite a bit of it. So the patient's tumor in the orbit had caused vision loss in that eye. The tumor, because it was filling the face, caused quite a bit of disfigurement. The tumor was also compressing the auditory canal on the right, causing a hearing deficit. It was also infiltrating the palate and by the teeth here, which created issues with chewing. And while you can't see it, in the bottom right, the airway is quite compressed. And while you don't have a picture of the patient actually came to us with a tracheostomy that had been put in several years before that. And so, based upon the fact that we have significant morbidity, I would recommend starting treatment in this case. Then the question is, what would I treat with? And I go back to those 2 questions. How do you think about surgery first? And I always start with, is it resectable without significant morbidity? And I think you can understand, having seen those pictures and how infiltrative this is, that to try and take this tumor out would have caused a lot of complications. And so then we thought about medical treatment or a clinical trial. And so in this case, we were considering Cellumetinib. And so we had to think about, did the patient have any underlying heart disease or retinal problems that would be concerning with a MEK inhibitor? Could the patient swallow capsules whole, etc.? And in the end, we recommended Cellumetinib for this patient. But I'll remind you, this was once again a multidisciplinary team evaluation deciding which therapeutic approach made the most sense. So now I'm going to pass back to Connie and Katie to just comment a little bit on the role of nursing in the care of a patient who you're getting started on a MEK inhibitor.
Thanks, Mike. So as the advanced practice nurse, we are also collaborating within the multidisciplinary NF and oncology team. We are involved with identifying comorbidities and other risk factors that may make this patient a good candidate or not to start these therapies. And one thing to consider as we're prescribing is that, can these children actually swallow pills? So is this feasible? And then consulting other members of our multidisciplinary team when needed. For example, Child Life for supporting the patients and families through these transitions.
So the nurse navigator or nurse coordinator can help with coordinating the baseline evaluations, including ophthalmology, echo, EKG, labs, and MRI, to ensure it is safe to begin Cellumetinib. Nurses can also provide some anticipatory guidance to families, such as discussing a plan for what time of day to take the medication, and ensuring families understand the guidance for taking the medication on an empty stomach.
Okay, so our next case is a 19-year-old woman with abdominal pain and a mass. She has no past medical history, so previously well, and not taking any medications. 3 months ago, she awoke from sleep with acute right-sided upper abdominal pain. She was seen in a local ED, and its CAT scan revealed a right-sided abdominal mass. She underwent an IR-guided biopsy, which revealed a plexiform neurofibroma. She's seen by genetics, who diagnosed NF1 and referred her to oncology. So Mike, as the referring team, would you treat this patient's tumor?
But I still go back to the few questions I always think about. So the first is the tumor growing? And it's interesting, right? This is a 19-year-old, but we have no idea whether this tumor is growing because this is the patient's first scan, because the patient didn't even know they had NF1 until they got the biopsy that found the plexiform. So we don't know whether it's growing or not. But I do think then about the age of the patient, right? And this patient is older, 19. So the odds would say to me that the tumor is probably not growing, or if it's growing very slowly and probably in the phase where it's probably going to stop growing. So the next question is there significant morbidity or impending morbidity? And so let's think about it. So this patient is pain, but the pain was described as brief episodes once to twice a day and not that severe. There were no associated GI symptoms, and it was not interfering with the patient's function or activities of daily living. She was still going to work every day. And so in the end, because it wasn't causing profound morbidity, and the patient was older and we didn't know that it was a growing tumor, my initial recommendation was observation with interval MRI and physical exams. And I offered for the patient to consider a neuropathic pain med like gabapentin if the pain persisted or worsened. And so now I'm going to hand back to Connie and Andrea to talk about the role of the RN in a patient with a known plexiform like this who you're going to be following.
Great, thanks, Mike. So one thing to consider specifically in a patient like this is continued pain assessment and management, and if there are any neurologic changes which may want you to reassess the patient and if there are any changes. And then also supportive care, which can involve pain medication or alternative and complementary therapies to offer if they do not want to take pharmacologic treatment for pain.
And so then from the nurse navigator coordinator standpoint, you're interacting regularly with the patient and family to find out if there are changing symptoms, and then assisting them to coordinate that interval MRI and exam that was requested. There are numerous times and opportunities for patient-family education, as well as a lot of psychosocial and emotional support through this process, and then being able to really direct the patient and family to national, regional, and even local NF organizations for support.
Great. So what happened with this patient? Were we right? So at least as of now, it seems like we made the right decision. It's 2 years later. The tumor has not grown at all. The patient continues to have some mild and brief episodes of pain, but still uninterested in trying any pain medications, which sort of is reflective of the fact that the pain is mild. And so the really important take-home point of this case is that the size of the tumor is not necessarily a factor in deciding whether to treat. This was a very large tumor that we decided not to treat, and that thus far has bared out to be the right decision. Meanwhile, I've got patients with tiny tumors in a bad location that are causing morbidity who I do decide to treat. On the flip side, right, what if the following, right? So what if the tumor had grown over time? Well, if the tumor was growing, I'd have to consider that. A lot of that would depend upon how quickly, on how much. So if it was just a little bit of tumor growth over the next year or two, a couple of millimeters, maybe not. If it was rapid tumor growth, then I would have to think about it. And then I need to think about, if the tumor's grown a bit, has it caused an increase in symptoms or an impact on function, right? So if those things had happened, then I might consider treatment. Specifically for this patient, if the pain had become intractable at some point and the patient tried pain meds and I couldn't control the pain with pain meds, then I might consider treating this tumor with Cellumetinib or offering a clinical trial. So we're going to move on to the third case. This is a 14-year-old boy who we started on Cellumetinib for a right shoulder plexiform neurofibroma that was causing neuropathic pain, so shooting pains down his right arm, and also causing some mild weakness of that arm. And several cycles into Cellumetinib, he presented with a severe acneiform rash and paronychia of his toes. So, Katie, I'm going to ask you this. How would you manage these toxicities that are associated with MEK inhibitors in this child?
Sure, thanks, Mike. So as you can see from these images, acne associated with the MEK inhibitors can be pretty severe. We recommend sending all adolescents being treated with a MEK inhibitor home with a prescription for topical clindamycin to be used in the event that acne does appear, and we recommend sending them with this prescription when you start the MEK inhibitor. We also have a low threshold for prescribing oral doxycycline to treat acne, and if the acne is refractory to doxycycline, minocycline could be prescribed instead. Topical hydrocortisone or triamcinolone creams could also be used in combination with the clindamycin and/or doxycycline. And kind of a general recommendation is for patients to use an over-the-counter benzoyl peroxide wash on a daily basis, and a moisturizer can be used if these medications dry out the skin. While our group does not have any experience with bleach baths, some institutions swear by these to help improve acne. Additionally, a referral to dermatology may be appropriate for severe cases of acne with limited response to these therapies. We usually start with a prescription for Clinda and Doxy, but if things are progressing, we can escalate to other items. And in some patients, a drug hold may be necessary to allow the acne to resolve with the supportive medications before adding the MEK inhibitor back in. So in this picture, you can see paronychia of the big toe. It is important to offer anticipatory guidance to patients and families that at the first sign of redness or pain around a finger or toe nail bed, they should begin soaking the affected hand or foot in warm water for at least 10 to 15 minutes, 3 or more times each day. Alternate options to warm water for soaking are vinegar or chlorhexidine soaks, but warm water is generally a good place to start. You could also prescribe topical mupirocin and triamcinolone ointments for up to 2 weeks. And fluorandrenolide tape could also be used in combination with these interventions. And if this is used, we recommend applying this nightly so that the tape stays in place while patients are sleeping. If paronychia is severe or refractory to these interventions, you could try a course of oral clindamycin, but ultimately a referral to podiatry may be necessary. While not relevant for this case specifically, we also wanted to mention a few recommendations for management of other skin toxicities that can be seen with MEK inhibitors. For patients who develop eczema-like rashes, triamcinolone ointment or cream can be applied to flared areas. It's also important to counsel patients on lifestyle changes such as limiting bathing or showering to less than 10 minutes, avoiding hot water in the shower, using gentle, non-fragrant soaps, and moisturizing twice a day, including within 2 minutes of getting out of the shower. For patients complaining of a dry, flaky scalp or dandruff, ketoconazole shampoo may be used, and any acne on the scalp can be treated with topical clindamycin. As far as the nursing role in assessing for skin toxicities, nurses can play a vital role in this, especially between appointments. This may include checking in with patients by phone or reviewing pictures of rashes that are sent electronically and escalating any concerns to the advanced practice nurse or physician as needed. The patient and family education is also important, such as educating families to watch for any symptoms of paronychia so that soaking can begin at the first signs of redness or pain. I'm going to turn it over to Connie to tell us a little bit about the advanced practice nurse role.
Thanks, Katie. Just a little to build upon, what you had mentioned. So continued skin assessment, prescribing the treatments as you had described, and then also within the team is to escalate to dermatology as needed.
Those are the cases. We chose plexiform cases to go with a theme, but many of those same points would have been relevant even if we had chosen glioma cases. But we only had time for 3 cases. So we're going to sum up now before we move into a question and answer period. And so what I'd like to sum with is just making sure that people understand that patients with NF1 are at high risk for both benign and malignant tumors. And it's important not just to be imaging patients with MRI scan, but really evaluating how the tumor affects function, because how the tumor affects function very often impacts on how we decide whom to treat. Specifically for plexiform neurofibromas, the existing therapies up until now were limited to surgery, but the newer therapies, particularly MEK inhibitors, have gotten us very excited about the future of management of this tumor. And many of the newer agents that I showed you some snippets of are also showing some potential to decrease tumor size and improve function. But I'll point out once again that Cellumetinib right now is the only drug that's currently approved, and it's approved for treating children with symptomatic and inoperable plexiforms. As far as low-grade gliomas go, chemotherapy is certainly an effective treatment option and what we lead with, but we don't get as much visual improvement as we would hope. And as I hope we showed you, there's a lot of promise for MEK inhibitors for this tumor as well. And so, with the unprecedented activity at this point of the MEK inhibitors is really changing how we think about managing these tumors, and we're really excited about what we can offer patients in the future.
So just some take-home points for both staff nurses and advanced practice nurses as part of the multidisciplinary team caring for these patients. These patients with NF1 should receive these timely evaluations by the multidisciplinary team, including specialists and nurses for the initial assessment and continued follow-up evaluations. As nurses, we directly engage with patients and their families to provide access to current information on clinical research and then also treatment options in NF1. We are involved in symptom management, prevention of complications, and family-centered care and education about NF1, and collaborate with our physician colleagues in the direct care of these patients.
So it's really an exciting time in NF1. The field in the last 5 to 10 years has really changed rapidly, and I think is going to continue to change rapidly. There are several natural history studies ongoing, one for optic pathway gliomas, one for plexiform neurofibromas, which I believe will help us make better recommendations in the future about how to follow patients and who to treat. As you've seen, hopefully from this talk, there are new therapies and new potential emerging therapies that are being evaluated. And so I think it's really a time where things are going to change rapidly for our patients, and the options for them are going to get better and better. And really all of this is happening because the NF community really has come together. So our patients and families, our patient advocates, our foundations, are all partnering with the clinicians, the clinical researchers, and the lab researchers to really push things together rapidly. So I'm very optimistic about the future for patients with NF1. So we're going to shift now and take a few questions from the audience.
Okay, so some questions that have come up today are, number one, how do you treat neurofibrosarcoma? So I will give this one to Mike.
Yeah, wow, we could have a whole talk on that. That's really complicated. So neurofibrosarcoma is another name for a malignant peripheral nerve sheath tumor. It was, I think, as mentioned by Katie earlier, these are really aggressive tumors. They are frank sarcomas and very hard to treat. The basics, though, are excellent local control, usually with aggressive resection, and radiation. Obviously, there are some fears about using radiation in a patient with NF1 because of the risk of second malignancies. But remember, this is a primary, very aggressive malignancy, so very often you still need to use that. And then various chemo regimens have been utilized with some brief tumor control, but none of them I would say are overwhelmingly very impressive. and many newer targeted agents are under evaluation right now. So why don't I ask the second question? This question has to do with what are the key developmental and behavioral issues that are seen in infants and children with NF1. Connie, do you want to start with this one?
Sure. So it's important to realize that these developmental and behavioral issues are actually present even at infancy, and they'll manifest themselves as the child progresses in age. So in infants, you'll see developmental delays. So it's important to involve early intervention to get support for these patients. And as you move on into your school age and teen years, it's really that's when you're able to assess for learning differences and behavioral issues. And so that is going to be involving, as Andrea mentioned earlier, support for these families around integration with school and then also with their peers.
The other thing I would add is, depending upon how profound the learning issue is, will depend upon when you see it. So kids with global delays present obviously in infancy with delayed development. But children with a subtle learning issue, it may not come out till they get to an age in school where the demands are really putting a stress on their ability to perform the work. So, for example, a kid with a subtle attention problem, you may not pick up until, let's say junior high school, when school is getting harder or not. And so it's really important to understand that if you're following a patient who's been doing okay in school and suddenly is dropping off in school, never make the assumption in a kid with NF1, well, he's just a teenager, he's not trying hard enough. Given the frequency of learning issues, you should always, in the back of your mind, consider whether you need to have formal testing in that standpoint. Great. It looks like we have time for one more question, and this looks to be about interdisciplinary care coordination. So the question has to do with what teams are involved, how regularly are kids followed, and maybe I'll ask Andrea if she wants to tackle that question.
Sure, thank you. I think really as the navigator or coordinator, there is constant care coordination. And as we've discussed, there's so many body systems and complexities for these patients. So you're really, in addition to their yearly basic NF follow-up, there's care coordination with so many providers. Some institutions are fortunate, as we are, to have a multidisciplinary clinic that meets once a month. And we are so blessed to have so many providers. So we have the NF specialists, neuro-ophthalmology, neurology, developmental peds, orthopedics, speech, and also neuropsychology involved. And so we meet once a month with these providers that the patients need. And so follow-up can be as needed and catered to the individual patient's needs with each of those departments. It's sort of a way to connect them, though. And as the coordinator, there are often times where the patient may not be able to come to multidisciplinary clinic, but I'm sort of a liaison between these various specialists and looking for ways to coordinate the care between the families and the different providers and really collaborate and look for best ways to support them.
So thank you for joining us this evening.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/BQF860. This activity is supported by an independent educational grant from AstraZeneca. This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.